Welcome to the Explainer. So, diabetic ketoacidosis, DKA. We all know it's a massive medical emergency. The second that patient rolls through the hospital doors, the clock is literally ticking. Today, we're giving you a high-stakes, rapid-fire crash course on mastering the updated 2023 adult DKA protocol. We're going to take those heavy, complex guidelines and turn them into a sharp, actionable roadmap you can use the second you step onto the wards.
This entire explainer is built straight from the revised March 2023 guidelines from the Joint British Diabetes Societies for Inpatient Care, and it's heavily backed by major hitters like Diabetes UK. Basically, this is the absolute gold standard UK consensus right now. Grab your phone if you want. You can actually scan the QR code you see right here and pull the full document up for your next shift.
Okay, let's map out our cognitive roadmap. Chronologically, here's what we're looking at. 1. The DKA emergency. 2. The diagnostic triad. 3. The first 60 minutes. 4. Stabilization and monitoring. 5. Crucial 2023 updates. And 6. Special renal cases. Let's get right into it.
Section 1. The DKA emergency.
So why are we zooming in on this protocol right now? Well, while DKA is completely preventable, it's still incredibly common. And sure, actual mortality from DKA is thankfully pretty low these days. But, and here's the kicker, it's the mismanagement after they hit the admission ward that really drives up severe complications and massive lengths of stay. Oh, and here's a brilliant little logistical update right out of the gate to clear up ward confusion. For your 16 to 18-year-old patients, if they are under the care of the adult diabetes team, you can now just use this exact adult protocol. No more second-guessing the pediatric guidelines in those crossover cases.
All right, moving to Section 2, the diagnostic triad. Picture it. You're sizing up a really acutely unwell patient right in front of you. When do you pull the trigger on the emergency pathway? Well, you've got to burn this rule of 3 into your brain. First, a capillary blood glucose greater than 11 millimoles per liter. Second, capillary ketones over 3 or urine ketones of 2+ or more. And third, a venous pH of less than 7.3 and or a bicarb under 15. If your patient hits those 3 marks, bam, they're in DKA. No time to wait, you act immediately.
Let's lay out your battle plan on a timeline. We start precisely at T0. The patient arrives, and your absolute #1 priority before literally anything else is restoring their circulating volume. The next 60 minutes are absolutely make or break.
Which brings us to Section 3, the first 60 minutes.
Rapid, decisive action here prevents a total disaster. If you can't get IV access immediately, don't mess around, call critical care right then and there. But once you do have a line in, focus all your attention on one specific number, 90. A systolic blood pressure of 90 millimeters of mercury is your ultimate fork in the road. As soon as you establish that IV access, checking that systolic dictates your entire fluid pathway. Here's exactly how that fork in the road plays out. If their systolic is below 90, you are dealing with a profoundly volume-depleted patient. You need to slam 500 mL of 0.9% normal saline over just 10 to 15 minutes. Check again. If it's still below 90 after that, you repeat the bolus and immediately get a senior review and critical care on the phone. Now, on the flip side, if their systolic is 90 or above when they arrive, your path is slightly less aggressive. Run 1 liter of normal saline over that first 60 minutes. Okay, so at the exact same time those fluids are running, you pivot to Action 2, locking in your fixed-rate intravenous insulin infusion. You set this at 0.1 units per kilo per hour, based on their estimated weight. But listen up, because this is an incredibly crucial point that gets missed on the wards all the time. You must continue their usual long-acting analog insulin, like glargine or detamir, at its normal dose and time. Never, ever stop their basal insulin. All right, let's bump down our timeline a bit. That intense first hour is over, the vitals are starting to settle, and we shift into our next phase.
Section 4. Stabilization and monitoring.
So from hour 1 to hour 6, we transition from pure emergency resuscitation into strict metabolic control. You're aiming for really specific targets here, dropping those ketones by at least 0.5 or bumping up the bicarb by 3 per hour. But here is your major danger zone, potassium. Nailing this in the second liter of fluid is notoriously tricky under pressure. Honestly, just take a mental screenshot of this clean little table right now. Potassium over 5.5, give nothing. Between 3.5 and 5.5, you must add 40 millimoles to their infusion bag. But if it drops below 3.5, stop. Get a senior review immediately for targeted replacement.
Section 5. Crucial 2023 updates.
Now, past audits showed a really concerning trend. Patients were developing severe iatrogenic complications. Essentially, the treatment itself was causing massive problems. So, the 2023 update introduces a vital new recommendation, 0.05. When your patient's blood glucose drops below 14, you really need to consider slashing your fixed-rate insulin infusion right in half. Cut it from 0.1 down to 0.05 units per kilo per hour. They found that keeping it at 0.1 was just driving far too many dangerous episodes of hypoglycemia and hypokalemia, even if you were running glucose alongside it.
Section 6. Special cases.
Of course, not every DKA presentation is going to fit perfectly into a neat standard protocol, right? This is especially true for patients with end-stage renal failure, or ESRF. Think about it. In standard DKA, patients are losing massive amounts of potassium through osmotic diuresis, which is why we usually replace it so aggressively. But your ESRF patients, they don't have that diuresis. They aren't losing the potassium. Because of that, potassium supplementation is usually not required for them. In fact, their severe acidosis can trigger rapid, fatal hyperkalemia. For these patients, continuous cardiac monitoring is an absolute must, and you've got to loop in the renal or critical care teams right away for potential hemodialysis.
And just like that, we've hit the end of the roadmap. We nailed the triad, sorted the immediate fluids, balanced the critical potassium, highlighted that new 0.05 insulin de-escalation step, and flagged the hidden dangers of ESRF. You've got the core of the 2023 JBDS consensus locked and loaded. So I'll leave you with this. You know the algorithm now, but how are you going to run these golden hours on your very next shift to save a life and prevent a readmission? Keep this explainer in your back pocket, trust the protocol, and take total command of the emergency. Thanks so much for joining us.